welcome to AO Link session 7 on the shoulder girdle. So we're going to get started here. AO Link is a webinar specifically for medical students, and we're in iteration 2, episode 7, and we welcome everyone here. We've got Dr. Aker with us today, who's the brains behind the operation, our liege, our guide. Any words, Tim, as students are rapidly approaching match day and getting ready to open their letter?
Yeah, that's a great point because one of my colleagues likes to talk about match day as a lot of the students think that they've just crushed the finish line and hallelujah, congratulations, you matched, you've done it. But in actuality, match day is just the start. It's really the start of the journey. And rather than taking your foot off the gas, that's the time to really dig in and start reading more. And a lot of the students have a couple months off, they have vacations, they have time, and they have a light schedule. But what a better time than to just dig into some journal articles, grab a textbook, get ahead, start reading. It's never too soon to start reading. So that would be my advice. First, celebrate that you matched, then get back to work.
Excellent. Excellent advice. I'm Phil Mitchell out of Nashville, and then Taylor Young is on the clickety clacks tonight in the Q&A box, and got a couple of cases that he has submitted as well that we're going to review, and appreciate Taylor here from Texas, El Paso. Wonderful guest faculty backed by popular demand. Augie, why don't you introduce yourself, where you're at, where you're from, and then maybe one of your pearls about that last month before match day, maybe a pearl about match day itself. What would you tell our students?
Yeah, so Augie Saez, I'm at UC Davis, born and raised in the great state of Wisconsin, transplant out there now, but love it. I think, that last month, I think after match, you have a lot of time, relax, celebrate. You know, what I did with that month before is, you're done with all your AIs and everything. Just pick something that you think that you want to improve on. So I did actually a rotation in the surgical ICU because I just want to get a better understanding of how like these trauma patients are treated. So like Dr. Aker said, it's never, too soon to, always be increasing your knowledge. So don't get too relaxed on the way out. Still got, there's always some more stuff you can add to the armamentarium.
Excellent advice. And Jerry Chang also with us. Jerry, tell us where you're at, where you're from, and then a pearl, if you will.
Hi, everyone. My name is Jerry Chang, and I am at Dartmouth Hitchcock. I've been here practicing for about 3.5 years. I did my fellowship in Houston, same place as Phil and Augie. And then obviously I'm working where Taylor did his residency. So it's one big happy family. I'm from Wichita, Kansas. And Pearl for, have people submitted their lists yet?
Not yet.
Not yet?
We're in the love letter stage right now.
Oh, okay. All right. Well, Pearl about that. I would just say it's easy to overthink it, kind of prioritize certain things and start scoring things. But I would just it sounds cliche, but just go with your gut. Just try and rank it by places that you think you'd be happiest.
Awesome. Great advice. I'll add one final match day advice special. We'll have one more session next month before match day. My advice, if you have mentors that have helped you through the process, that have guided you, that have emailed for you, when you find out where you match, after you call your family and friends, let your mentors know how things went, how you did. We want to know very badly, and we've invested in y'all as well, and want you to succeed. And so it's a nice way to tip the hat to your mentor to say, Dr. Aker, I matched at my #1. I'm so thrilled. Thank you for everything you've done. And so that'll be my piece of advice. It's easy to forget on that day when things are crazy, you're crying and you're happy, but don't forget about Dr. Aker.
Tears of joy, hopefully.
We hope. So here's where we're at. We're on fractures of the shoulder girdle. We've got 3 more following this next month, infections. But tonight we're going to focus on the shoulder. AO Milestones, another plug for this as you begin your residency training, and excellent program that will also help you track your surgical education. If you have a question, we love the questions. The questions have been terrific. Q&A box for the questions, and Taylor will be on the blacks and the whites, the clickety clacks to answer your questions. So if you want to watch again on YouTube, all these are on YouTube. We may reference previous episodes that are on YouTube, and those are available. And then you'll get a link to claim your Cudley badge. I will say, this is, if you're in the running for the final merit badge, and you're a MS3, you can put this on your application to residency, and it may come up in some way. I've seen it a few times this year, as I think a few of us have. So if you've put in the work and attended all these sessions, get those badges and get your final merit badge. Really encourage that. So we lean heavily on our AO principles as we've reviewed throughout the course here. Our learning objectives tonight: first, to review some of the anatomic considerations and the treatment options for proximal humerus fractures. That's going to be about the first half. Secondly, to understand some of the types and management of shoulder dislocations and fracture dislocations. And lastly, operative versus non-operative indications for clavicle fracture and maybe some of the details associated with that. So as a recap, we went over distal radius and forearm last week. We showed injuries from the left-sided simple to the right-sided more complex and comminuted, and the different treatments, which can range from the left-sided simple volar plate to the right-sided bridge plate in those more comminuted unstable patterns. We also reviewed other treatment options. The far left image here is an external fixator applied across a very, very contaminated comminuted distal radius fracture. We talked about surfaces of plating, both for the radius and the ulna, what happens if you have extension into the radial shaft and how you manage that, and then some simple both bone forearm fractures. And then finally, we covered some of those eponyms you may hear in your clinic or in your call, and those are shown here. And if you want further details about these types of cases, highly encourage that discussion. Review of that YouTube video is excellent. So we're going to talk about shoulder tonight. It really covers a vast spectrum of injury severity, which we've seen in other anatomic locations, but also a variety of anatomy, not only just the proximal humerus, but the AC joint, the clavicle, the scapula, and we're going to cover a variety of different cases tonight. So I'm going to start with a case first here. This is a patient of mine, 80-year-old ground level fall. Augie, I'm going to go to you. You have a student with you in clinic. You've just sent them into the room. What do you want them to come out and tell you about this x-ray and about this patient?
Yeah, so I think first off, looking at the X-ray and describing it, you gotta have some sort of understanding what a normal proximal humerus looks like, and then what you're really trying to pick up on is severity of displacement, and whether the joint's reduced or not. When I say joint, glenohumeral joint, so the joint between the scapula, the glenoid, and then the humeral head. And then really this discussion really centers on the patient. I want to know their activity level, and not people always get confused. Like, what does that mean? Like, I want to know what their everyday life looks like. Are they waking up and working out, or do they have a hobby of fly fishing? Do they work in construction? Do they do a lot of stuff overhead? Do they play tennis? Or are they on more of a spectrum where, they have COPD, they have bad coronary artery disease, they're in a skilled nursing facility or assisted living, and most of the day is about, getting around with a front wheel walker and playing board games and watching TV. There's a spectrum, and I think for a lot of upper extremity that kind of drives some of our decision making. So what I really need is a detailed history of what that patient does and then what they're trying to get back to, because that will help drive some of your management.
Excellent. Jerry, any other thoughts to add to what Augie was saying there? I mean, 80-year-old, I feel like an 80-year-old in different areas of the country in different activity levels, it can mean a variety of different things. So anything to add in regards to that?
Not really. I would say that is similar to, the things that we focus on. I think he said upper extremity, it's a little bit more gray. So a lot of these need to be tailored to sort of the individual circumstances.
One
Nice.
thing I'd add too, Phil, is I always want to know about prior shoulder pathology. At 80 years old, has this person had a massive rotator cuff tear? Have they had multiple like rotator cuff repairs or been treated non-op, I think, that goes into a huge part of what your management's going to be also.
That's an excellent point. I think you give a lot of great tips on how to evaluate these patients. It's an opportunity as a student if you go into the clinic room and then come out and provide some of those details. No pre-existing shoulder pain. They're right hand dominant before they were playing tennis with this extremity. All these details kind of add up and give the faculty you're working with or the resident you're working with a good picture and an opportunity to shine and show also your knowledge level. And so with a picture, an x-ray like this, are any additional views necessary? Like for you, Augie, what's the minimum number of shoulder x-rays to appropriately manage and obtain a treatment plan?
Yeah, so usually at least 3 views, some sort of AP, which I'm looking at now, typically a Gracie view looking directly down the glenohumeral joint, and then axillary typically, or a Velpo. It just depends how compliant the patient is, how much pain they're having. To really make sure, kind of get a sagittal alignment as well as look at that glenohumeral joint to make sure it's reduced in 2 views.
Yeah, we'll go over some of the details about the different shoulder views in a few cases as well, but I think that's critically important. First, making sure that you have the views you need to make a treatment plan, making sure the shoulder's reduced, which with any proximal humerus fracture, you're never going to be wrong to say that you want to confirm that. So Dr. Aker, she also has an intertroch fracture on the right side. She fell, she broke her right hip. Does that change anything for you with this patient?
No, I think a lot of times the students may be thinking that polytrauma is a good indication for us to fix a humeral shaft because that really helps patients mobilize and use a trapeze and use crutches and weight bear on their arm. In general, older folks, if you're telling me this is an 80-year-old grandma, um, even if we fix it or don't fix it, she's probably going to be in a sling and probably not going to let her weight bear on this with crutches or a walker. So it's certainly another topic to discuss with the patient, but right off the bat, I think the hip will take priority. And let's give the shoulder a couple days. Actually, I had this very scenario a couple weeks ago, and we kind of gave it a couple days to cool off. And once the patient realized that every day he was feeling better with regards to his shoulder, he was like, please, I don't want any more surgery. If I can avoid it, I don't want to do that again. And we saw him in the clinic at follow-up, and he was feeling better and better.
Yeah, I think that's a critical point, especially when we're talking about humeral shafts and using polytrauma as a relative indication for proximal humerus fractures. That's not really a relative indication, so particularly in an elder patient who's 80 years old and low energy fall. So um, here's the 6-week follow-up x-rays. And then we do have 2-year films whenever she came back in for another malady, but ended up healing. What would you expect from a shoulder function standpoint, Augie, with a patient like this? And then maybe talk about goals with an elder, like activity. What are the goals in an 80-year-old in regards to shoulder function?
Yeah, I think here, I mean, clearly there's been some further displacement, but there is union. I mean, I expect her to be able to do tabletop activities, so a lot of stuff in front of her, eating, you know, typing, texting, reading a book, stuff like that. I expect, a lot of times they still have good internal rotation, so be able to do like personal hygiene or get to the back. Tends to be less of an issue. Expect her to have some limitations with external rotation and some forward flexion. The deltoid can get your arm pretty high. She may be, still be able to get it, to her head to like do hygiene and maybe do some of her hair. I don't think she's probably getting like 150, 160, 180 degrees up. But it depends again on her level of function. Like, is she going to get out of bed, take a shower, feed herself, cook? Yeah, all that stuff. I mean, we live a lot kind of in this box between like eye level to waist, right? So I think all those activities are probably still going to be doable for her.
Yeah, I think really important points in regards to activity, taking care of yourself, feeding yourself, doing your hair, those kind of things in terms of goals, maybe not reaching up to the top cupboard. But when you're setting expectations after these, often they can end up a little bit stiff. But the goal is for somebody to still be able to take care of themselves. So I promise that's one of two non-operative cases. The rest are very, very juicy fracture fixation, but important points because you'll see a fair number of non-operative proximal humerus in practice. So,
Sometimes those
Yeah,
X-rays can
Phil.
surprise
Oh,
you.
sorry. Go ahead, Jerry.
No, I'm just saying sometimes those X-rays can surprise you. You could see something like that where you've seen, as it heals, becomes more displaced, it just doesn't look right, but they have pretty good function. And you'd be surprised sometimes they can get their high flexion.
totally. So we'll just review a little bit of shoulder anatomy. This is going to be pertinent to the next case, but I guess in terms of a kind of a minimum knowledge here, Augie, from a bony standpoint, what are some of the minimum expectations for a student in clinic to understand about the proximal humerus?
Yeah, I think the key to understand the proximal humerus is really understanding kind of two parts, the articulation and then also where things attach, right? So I think you got to understand that it's a joint. So we really care about the articular surface. You have to have an understanding of what that consists of, which is mostly the humeral head. You have to understand, though, that really what drives our management sometimes in the proximal humerus, the things that are going to cause it to displace or the things that are going to cause blocks the motion. So understanding where rotator cuff attachments are and the greater tuberosity and the lesser tuberosity. And then I think the last part is, where that kind of metaphyseal to aphyseal junction is, because that's going to be critical. And then again, looking here, you can see the biceps tunnel here where the tendon runs. That's important. It's a good landmark. And then understanding the relationship of the tuberosities to the anatomic surface, right? Like the head relative to the shaft, because there's a built-in retroversion to the humerus. And so if you're trying to fix it and you're trying to restore anatomy, you gotta understand what that parameter actually is, right? So if you fix it without it in retroversion, then you're actually causing a problem.
Yeah, so I've highlighted a variety of areas here. First, the humeral head in yellow, the anatomic neck in red. Just really pay particular attention to the greater tuberosity before we go into this next case. This highlighted area in blue, a pretty broad area where you're going to have attachments for the rotator cuff, and then the lesser tuberosity where the subscapularis is going to attach. So this is a little bit more of a pictogram showing that with some sutures in play. A wise man told me a proximal humerus surgery is actually a soft tissue operation. So the cuff, the muscles that are attaching around the shoulder, so important with these cases as you're doing them. And then over that envelope of the rotator cuff, you've got the biceps tendon running in its groove. And then you've got the nerves and the arteries and the veins medial, the deltoid enveloping everything as well. So important to know the anatomy in this case, as always, and will become particularly important as we go to this next case. The final thing I'll pull out is the axillary nerve, knowledge of its location, and particularly the distance of the axillary nerve from different landmarks on the humerus. And so if you were going to study something before a proximal humerus case, this would be one of the prime areas of study to know how far the axillary nerve is from a variety of palpable landmarks around the humerus. So we're gonna go to the next case. 41-year-old male, right hand dominant, had a pan-talar dislocation shown on this left-handed image. And then these are his initial shoulder x-rays. And so, Jerry, what do you see in on these shoulder films? Anything you'd expect a student to see and note on this?
So in describing the film, I would expect the medical student to describe what we're looking at, which here, this is an AP view of the shoulder, AP view of the right shoulder, and be able to comment on if they see any pathology. In this case, you can see some cortical fragment near where the greater tuberosity is. It does look displaced. And other than that, you can't really say too much, I think, on this view in terms of if the glenohumeral joint is congruent or it's sublux dislocated. They need some more views for that.
Okay, so always an proximal humerus, assess if the shoulder is reduced. Is that a fair assessment, assertion?
Yeah, you need enough images to be able to confirm. Usually on an axillary, you can confirm because oftentimes it's either posterior or anteriorly dislocated. So an axillary view kind of going up from the armpit or down in the Bellevue view to assess, where is the humeral head relative to the foot.
So sometimes patients will have the CT traumagram, chest, abdomen, pelvis. You can get assessment on that as well. I've included a slice here, not necessarily to show that the shoulder was reduced, which it was, but this was one of those kind of oblique traumograms where the top part of the humerus was cut out. And so this is a really important case because I'm zoned in on the foot, on the ankle. I'm like, this talus, we got to get it back in. We got to get this thing pinned. And we see some crumbles and some kibbles up by the top of the humerus, but they don't look too bad. And so he comes back at clinic, and this is what he looks like. So Augie, what do you see and hear? Anything new concerning with this?
Yeah, so this Gracie view here, we're seeing what we thought we maybe saw, which is displacement and combination in the greater tuberosity. You can see some of the fragments up top, but then you also see a little bit of that double shadowing there. So yeah, big time concern for seeing displaced greater tuberosity. That's going to be an issue because you can just assume that's where the rotator cuff is sitting, not attached to the main, proximal humerus.
Hey, Tim, what do you think his exam's like?
Yeah, I mean, unfortunately, this patient now has a functional rotator cuff tear. So especially for a young patient, I think you said he was 40-ish. Functionally, you try to examine him, try to get him to elevate his arm, do any forward flexion, abduction. He's going to be super weak. He's not going to be able to do it. He'll have some gross shoulder motion thanks to the deltoid. But once you get into the real fine movements of the rotator cuff, 3 of the 4 are going to be affected here since the students have been studying what rotator cuff muscles go where on the shoulder, Phil.
Well, that's a great point. I think I'm gonna have an overlay here in just a second of this displaced greater tuberosity. So this was before, this was after. We see the pull of supraspinatus, infraspinatus, teres minor, pulling this greater tuberosity away. And so this is the CT scan that probably should have been attained while he was in the hospital. And we see it's actually a bit of an impressive amount of displacement. The entirety of that greater is displaced. It's highly comminuted. These are very frequently associated with a shoulder dislocation. So if a patient has a shoulder dislocation, you reduce it and the greater is still off, that to me is almost an operative indication at that point, at least worth a discussion if it is not kind of sitting right back where it needed to. So here's our displaced greater. Here's some extra bone formation. I think this was probably at about 4 weeks, and he had already started gumming it up, trying to heal this thing. And then here's where the rotator cuff is going to be sitting attached, displacing those fragments as he's tried to mobilize with his injured leg, with a shoulder that's not working, in crutches. And basically these are one of those patients that comes in and they just have the appearance of not having showered for like 3 to 4 weeks. And it's just out of pure misery and pain and the inability to raise the arm to shower. So you take a lot of pity on these folks because it is a true challenging situation. And you can, those usually get booked that next week or that next day. So again, coming back to our diagram here, if we overlay the profile of this surface rendering, we see it occupies the entirety of the greater. So thoughts on management on this one, Augie?
Yeah, what Dr. Aker is saying, this person has a rotator cuff tear, 40-year-old. I mean, this to me is operative. And so I'm having a discussion and recommending operative management for this. And when I do these, I mean, it's basically doing an open rotator cuff repair. So to me, there's not a great piece of bone here to fix and put a plate on and do all the things we normally like to do. So I'm really focusing on the rotator cuff aspect, doing a double row repair back down to the fractured bed. Even if there is kind of sometimes that cortical shell, which doesn't have a lot to it, I'm still doing that double row repair and then sometimes supplementing with a plate. But my real goal is to get wherever bone's still attached to the rotator cuff down into that donor bed and get that kind of bone to bone healing So that way that rotator cuff's repaired and then we can start the rehab process.
Nice. So here we did, just as you stated,
Sorry.
kind of double row repair, based on the size of the fragment, the amount of comminution. Jerry, could you get a little bit of a cliff notes for greater tuberosity fixation? So here we use suture anchors to repair this comminuted bit. What are some other options? And then how are you deciding what you're using?
Yeah, so you said it's a soft tissue repair, but I do find that if you can have clues of reduction and bone heals better to bone, to try at least, maybe if maybe if the piece is a little bigger, try and get some sort of visual reduction. And then I like to use, you can use a mesh plate or use some sort of mini fragment, small plate, and use that as not only for fixation of the bone, but also as your anchor. Because you'll have screws in that plate, it'll be anchored nicely in the bone, it won't move. And just have the sutures that you tie into the rotator cuff, tie into the plate, and then that can be your anchor.
Nice. So we're going to talk about approach here during this next case, because I think this is a great type of case for a deltoid split approach, where you're going to have direct access and dissect directly onto your grater. But we're going to talk about that in a second. But this is a great case for a deltoid split, and that's what we did in this case. In post-op, these get rehabbed like a rotator cuff. So it's one or two suture anchor cases a year, but really satisfying type of case, and patients really get a lot of benefit. Again, otherwise complete disability without going after this thing, even at 5-6 weeks. So, all right, I'll get this to your case.
Can I ask you real?
Go ahead.
Can
Yeah,
I
please.
ask you real quick on that last case? I've heard some folks say that bones aren't smart. They just once they fracture, they just go where the muscles pull them. They're kind of at the mercy of the muscles and the so-called distracting forces. So when you have a greater tuberosity fracture, are you just being hopeful and optimistic? Like, can treating that conservatively sometimes work? Maybe some of the students are thinking, oh, that was predictable. The muscles are just going to pull it. So why would you sit on it? Or what are the chances that maybe it's actually going to work with just a little therapy?
Yeah, I think a great question. I think like many injuries, it depends on the displacement. It depends if they had a dislocation, that to me reflects higher energy, more instability, and the greater chance that that piece may displace. I don't think it's insignificant that he had a lower extremity injury too, and was probably trying to kind of hobble around on one leg. And in proximal humerus, it seems patients have a little bit more difficulty with crutches and self-care, and they're relying on their arms more. They're pushing up in bed, they're really using their uppers. So I think that probably played a role. I I think there is a chance that if he had been immobilized, put in a sling with some external rotation, with a little bit of abduction, had not had dislocation with that fragmentation, sure, I think he had the potential to be treated non-op. I'd say one take home, bring him back early, because you start getting 4, 5, 6 weeks out, those fracture edges start getting a little bit more blunt. And then the patients too are further out from their time of injury. It's like now the recovery process has elongated from when maybe they get back to normal at 4 months. Now it's going to be 6 months because you're going to be doing shoulder rehab. So I think if there's area for improvement outside of that initial CT scan and recognizing, hey, this isn't enough, we got to get the full CT, because that AP view we didn't talk about, that also can be deceiving, that tuberosity is much more displaced posterior that you don't see on the AP. And so getting a CT to really understand that true displacement is important. So that would be an area that his care could have been improved. And then secondly, ensuring follow-up, maybe within 1 to 2 weeks, knowing, hey, if we catch this early, if we see displacement early, we're going to move and get this piece back down. So
Awesome.
any other thoughts?
No, that's great. Thank you.
Yeah. All right, Augie, what do you got? What do you see here? We've seen a non-op humerus. We saw one that wasn't so bad. I kind of saw a crack in the bone. I could, kind of squinted and it went away. Where is this on the spectrum of displacement for you, of operative versus non-operative?
Yeah, so you're looking at this AP and axillary. I mean, you can just see right now, so higher energy, right? So you're seeing the fragmentation, you're seeing some sort of fracture of the humeral head, maybe with metaphyseal spike on it. You're seeing a separated greater tuberosity fragment, maybe some comminution. But I think the thing I'm seeing the most is it looks like that humeral shaft has been impaled up into the head, right? And it's caused this sort of like splitting effect where that globe now has been kind of like exploded. And so I think this is just a little higher energy. I think you can get this thing to heal without surgery, but to me, if this heals in that position, which would be best case scenario, I think this person is going to be having some trouble.
Yeah, on the AP, things kind of look reasonable in terms of alignment overall, definitely some displacement on the lateral. Am I interpreting that correctly, that this is like almost a 90-degree,
Yeah.
amount of angulation? So reviewing both films, really important because the displacement, the angulation that reflects the degree of injury really shown on the axillary view here. So from a discussion standpoint, identifying that, recognizing that this is a high energy injury. Also, the mechanism important is going to help the decision making process and the discussion. So it sounds like you're leaning towards operative treatment based on that series of factors: the displacement, and the perceived instability. Any other features here that are pushing you one way or the other?
I mean, what else? I look at this, the question is it reconstructible? And I think the answer to that is almost 100% yes. So, I mean, I think, proximal humor sometimes gets a little bit of a bad rap because I think we've seen historically a lot of people just kind of like lob it together and put a plate on, and those people shockingly don't do well. But I think with a thoughtful preoperative plan here, I mean, this is something where you can get an anatom reduction and restore this person's function.
Nice. So you've put together this slide here, kind of describing some of the features maybe to identify, look for. And we identified on that last case first displacement, that just not the AP film showing that the alignment's okay, but that there's been some splitting, some wedging regards to the high energy fracture. The axillary showing the angulation, really reflective of the instability. And then in this patient, does the age or functional status, is it less important when you see that amount of displacement, or how are you taking that into account?
Yeah, less important for me unless this person's real like infirm and like doesn't do anything and is bedbound. I mean, even this person was 80 and trying to get some sort of function, like I think fixing that person's gonna give them the best outcome. So I mean, age always plays a little bit factor, functional status always plays a factor, of course. But I think, the worse the injury, the more likely I am to fix it, regardless, kind of and weigh the patient factors a little less. I think
Yeah,
this is an example I put in here of someone who came to my clinic like 2, 3 months out, treated non-operatively here. She was like 60 years old, swimmer, and she's like, I can't swim, I can't do anything. They told me this would heal and be fine. And in a way, it is healing, right? But it's healing in a way you can see that tuberosity's tilted in. She doesn't have the excursion, the rotator cuff's not functioning right. So did this, malunion repair. And at 6 weeks, she was right back in the pool. And honestly, one of the happiest patients because she was able to get back to doing something that she loves. So, you just gotta listen to the patients too and what, their goals are.
Dr. Aker, I've heard folks talk about the like near classification. Is this something that in clinic you expect students to know? Is this something that you're using in your decision making process for these fractures?
Yeah, I think anytime there's a classification on a specific body part and a type of injury, that's a great place to start for students is, to know the anatomy and know some of the classification systems. I do think they're important, and knowing the classification can certainly help drive the treatment algorithm. But one thing I would say should probably be a take home for the students, just to really hit it from like the 10,000-foot view. In general, there's always exceptions, but in my practice, in general, elderly patients with low energy fractures are generally treated non-operatively. The exact opposite is also true. Young patients with high energy fractures are almost always treated operatively. And y'all can start to figure out the rationale for the energy, the displacement, the functional status. Young patients usually don't get low energy fractures. They don't get fragility fractures of their shoulder. So it's going to be higher energy. With high energy comes displacement. With that displacement, like Phil, Augie, and Jerry were talking about, that displacement comes malunions and not a good functional result. So elderly, low energy, conservative; young, high energy, operative. That's where I would start if I was a student. Now, there are always exceptions, and we're building upon some of those exceptions here as we go. But that's a good sort of place to start with all these indications.
Yeah, I think the classification here can be useful for communication. So if you're a student, you have a good knowledge of this, and you go to see an elder patient with a proximal humerus, and you come out and say it's a two-part proximal humerus fracture, that already demonstrates that you've read about the classification. Then you say, well, why is it two parts? Are you basing that on displacement or angulation? And then you can get into some of the minutiae, and it shows that you have read some of what at this point was the earliest, best literature on this topic. So important to know the history, but there is, to Dr. Akers' point, it's a spectrum, it's bimodal, and sometimes the classification may not determine operative treatment, yes or no, but it can be helpful for communication. So it's a good one to have in your back pocket. So in terms of approach for this one, Augie, how'd you decide what approach to do?
Yeah, for this, some things that drive a deltopectoral approach and things that drive me that way. If there's a dislocation, which there was in this case, but also if I'm looking at my reads, and this person has a nice calcar spike that you can see is attached to the lesser tuberosity, which is attached to the humeral head. So I know I can reliably get that reduced to the humeral shaft. And for me, that drives my approach. So it's the fracture characteristics, ability to reduce the fracture anatomically. How can I do that best? How can I visualize that best in this case? And for me, that was a delta pec approach.
Yeah, I think we could have an entire webinar on deltoid split versus deltopec, and I anticipate there'll be questions that will come up in relation to this. But for those that are unfamiliar, it is important anatomy to understand that the deltopectoral approach is going to be the interval between the deltoid and the pectoralis major muscle, and that's going to be a little bit more medial on your skin incision. A deltoid split, which is going to give you a little bit more access directly onto that greater tuberosity fragment, is going to be a more laterally based incision, probably around where this deltoid dot is sitting on the left-handed image, and is going to be a more lateral incision with a little bit more lateral approach and visualization of that part of the humerus bone. So this picture on the right kind of shows that interval. So here's 3-month follow-up. It looks like you used a proximal humerus locking plate. And for any other details regarding locking plate, non-locking plate, we have covered that in the past, but this is a really critical, useful implant in these fractures. You're going to see the proximal humerus locking plate in almost all of these cases. So take us through this one. Now, Jerry, I'm going to throw this over to you. This is one of Augie's cases, but when you look at this, when you're thinking about approach, Augie just talked about doing a deltopectoral approach. Is that what you would do for this one? How are you deciding for a fracture like this one?
Yeah, I think whenever I'm making this decision, or lots of decisions, when you're doing surgery, you're constantly trying to make these decisions, and it's kind of weighing, understanding the factors and understanding the pros and cons of each one. So for this one, one of the pros that Augie said of the deltopec was it's more of an anterior approach. You have more anterior exposure. If you had direct visualization, if there was a cortical spike to visualize anteriorly, it's hard to see that in a deltoid split. So that makes more sense to do a deltopec here. And then on the flip side, the benefit of doing the deltoid split is that you're more lateral, your plate is going to be lateral, applying your implants, inserting your screws, being able to do that without having to retract the deltoid, without having to sort of put forces on the reduction that you've already taken so long to achieve, is the benefit of doing a deltoid split. So here, I don't think, you have impaction medially. You don't have as good of a read, or probably won't have a read medially. This, I think, would do well with doing a deltoid split. You do have to be mindful of the axillary nerve and dissect around it to do it. Also one of the downsides, but you'll be able to see your read. In this case, your read is lateral, so you get both.
I included this image. Augie noted that this was the preoperative plan of one of his residents, and an excellent example, maybe screenshot worthy of a very detailed preoperative plan. And as I was reading it, I noted that their approach was chosen to be a deltopectoral approach. And as we were talking about this case, I think this is wonderful because as a resident, when you are preoperative planning, I like to see you putting it all out there, just saying, this is what I'm gonna commit, I'm gonna do a deltopec, and then it opens up a wonderful discussion before the case. So I include the pre-op plan as an excellent example of it being detailed, but you don't have to be right. The point of you doing it is so that we can talk about it and for you to get better. So a great example here. So here's the deltoid split, not the deltopec that Augie did. A couple of things to point out. First, the fracture reduction that Jerry was talking about. You can see directly, you're dissecting directly down onto it to see that this reduces anatomically. It clicks in, and then the plate application on the right-handed images. This has suture into the cuff that is tied to the plate. Coming back to that last case, the muscular forces across some of these fracture fragments that are comminuted, negating that with suture, tying it to the plate. Such a critical part of the case. It's a soft tissue operation. A wise man named Tim Maker told me that once. So here are the post-ops looking excellent. So to recap, we talked operative versus non-operative proximal humerus. We really went over ORIF. I'm going to show a few cases from an arthroplasty or intramedullary standpoint here in a few minutes. Any questions, Taylor, to touch on?
Yeah, I just want to give a shout out to Sam for being the first person to ask a question. I've been sitting here, I'm kind of getting bored. I
There we
named
go.
this session a shoulder girdle because and brought on Augie, who got me like turned on by this term. It's like a girdle surgeon. It's like such a novel idea. But basically, Sam has a question about when you're putting your screws in the head. I'm sure we've all seen some where the screws are not in the head, they're out of the head. And so what are some strategies that you use to make sure you're not doing that? And are you aware of any literature to say you need this much, like your tip apex in the femur?
Augie, what do you think? How are you doing that to get just enough screw tip into the head, but not so that when the AVN sets in and the melting begins, you've got
Yeah.
screw tips that are touching the glenoid?
So what I'll do is, drill until you feel a change in the tactile feedback. You're getting pretty subchondral. I'll take the depth gauge and I tap, tap, tap until depth gauge is pretty safe. It's not going to go out. And then what I'll do is I'll measure. And I usually take 4 off because I found that even when they're taking 4 off, it seems like the locking screws set in a little bit further than that. And so I found that's a good way. I've never had any, intra-articular penetration that way. But what I'm also doing is I get CTs on almost all these, and just like, you measure like the posterior like plafond, and like when you're trying to figure out how long your screws are going to be for like a split. Same thing. I'm trying to measure that humeral head distance and figure out how much screw am I going to be able to get in there? How much thread am I going to be able to get in there? But as a rule of thumb, I usually take 4 off, except in the Calcar, I take 2 off. So I think Calcar, I'm trying to really maximize. Those screws are the most important.
But
Nice. You
there's
got
no literature as far as I'm aware. Would you agree?
Oh, I agree. I don't know the study.
Tim, you got any pearls?
There's plenty of pearls, but I don't want to go too far down the weeds. It starts to get pretty complicated, So from a med student standpoint, you want your screws long, you want them short of the articular surface, and the more points of fixation you can put in the head, the better.
Love it. All right, we'll move on to the next case. This 50-year-old female fell down from a curb, right-hand dominant. Taylor, your case, what are you seeing?
So this is a lady who fell off the curb, like you said. She is right-hand dominant. This is her right side, and so we're talking about activity levels and deciding about whether or not we fix this. But I think there's something here that we want you to recognize that suggests you probably have to do something rather than trying to potentially treat this one non-operatively. And so if you continue on, what you'll see here is that the shoulder is actually dislocated. And you can see this is not the best axillary, but gives you a sense that something's off there. And when my residents order an X-ray and they get an axillary, and I'm just not quite sure what's going on there, then usually I'm going to get a CT scan to better understand what is happening with the humeral head there and whether or not the glenohumeral joint is reduced. And so that's what we did well, one thing we want you to know is this is called a light bulb sign, where what's interesting on this X-ray is you rotate the arm, the head is not really moving, and so it's sort of locked. And this is a posterior dislocation, which shows up on the CT scan here.
Perfect. So I have a few slides in here about shoulder imaging, really just to highlight that an AP of a shoulder shown on this left-handed upper side in a Gracie view, where you're actually taking that beam and shooting it a more oblique beam down the plane of the scapula or the glenoid. Those are two different images. So when you hear that come up, that's important. Your scapular Y, and then different ways to get the axillary. We just saw the El Paso axillary shot down the axis of the humerus, but also have the Velpo in your back pocket as another way to get a good view. Here's the CT scan showing the head dislocated posteriorly here. So, Taylor, why don't you walk us through plan on this? 50-year-old fall off a curb, I've heard about replacing a shoulder. Is this a patient you would replace, and then why or why not?
It's certainly not one I would replace because I don't do any replacements, but I would ask a colleague if I felt that was necessary. I agree, like in Augie's case, that there is potentially a good read here along that calcar, and so I chose to do a deltopectoral approach for this one.
Awesome.
So, I think really scrutinizing your imaging is really critical here. And so you can see the dislocation a little bit better on this axillary view, and it's sort of wedged onto the humerus, onto the glenoid there. We call that a reverse Hill-Sachs lesion because the humeral head is dislocated posteriorly. And then, like we talked about at the very beginning, we are performing a direct reduction here, as you can see, with clamps, and we're squeezing things together with lag by technique fixation with these individual screws. And then we just left it there. We just left it like that. We didn't put anything else in, actually. So you can go to the next case.
For the med
Oh, no,
students,
just kidding. We did no. We did plate it because while that is excellent stability, we want to neutralize with an additional implant here. And for me, I did add a anterior base plate, similar to Augie's case, actually. And so we're really trying to optimize the fixation to neutralize the forces on those lag screws as well. And in the interest of time, we can probably skip the reverse Hill-Sachs discussion, I'd say.
Management of the small reverse Hill-Sachs versus large for another time. But I think critical point you bring up, adding additional fixation to allow some early motion. The shoulder is, patients with a stiff shoulder aren't very happy. And so we want to provide enough fixation to allow early mobilization, one of our AO principles. So, Jerry, another thought on this one?
well, I just wanted to highlight for the medical students, when you're looking at that AP view of the shoulder reduced, paying attention to that's what, the proximal humerus sort of looks like. That's more normal in an AP view. And that's why the light bulb sign that's what the clue of the light bulb. You're looking at a direct lateral view of the proximal humerus when you're looking at an AP of the shoulder, indicating that, you may have a posterior dislocation.
So slightly different, but the same patient of mine, 72-year-old guy. He had a seizure. He was brought in, worked up for a seizure. He eventually comes to and starts saying his shoulder is hurting, and they get x-rays and it shows this proximal humerus fracture dislocation. So slightly different from Taylor's example in that the humeral head is dislocated anteriorly in this case. And as you're trying to review shoulder imaging and deciding if it's an anterior or posterior dislocation, the coracoid can serve as a helpful landmark to know where you are at. And so here we see it's a patient with the bone quality a little bit worse, I would say, a little bit worse bone. The shoulder's been out for 3 days at least. And then the head component of this is a little bit more thin. So what are you thinking, Jerry, on this one? Similar approach, more of a discussion. Does arthroplasty come into the conversation with this? How are you deciding on a fracture like this?
I think when you have this amount of displacement, you have likely, a 3 or 4 part fracture, plus you have dislocation of the humeral head. Yeah, that articular fragment likely has no soft tissue attachment, no blood supply. And so, especially in a 72-year-old, I think trying to fix this would be sort of risky in terms of falling apart, and especially with how thin that humeral head looks on the CT scan, that would be my biggest concern. So I would counsel them and talk about the options, but sort of steer them towards something that is, I think, less likely to fail, and that would be a reverse total shoulder replacement. I think is perfectly appropriate, especially if someone's 72 years old.
Yeah, I think can be a discussion based on activity status, based on the patient's condition, their bone quality, a number of factors. I think the chronicity, it being 3 days out, may be a factor, but not the only factor. And again, we could do an entire webinar on fix or replace, but we'll kind of skip forward here just to show that I thought the head was a little bit thin. I thought the chronicity, the patient's medical status, all lended towards us advising a reverse total shoulder in this patient. So this is what he got for his fracture dislocation. Other treatment options for proximal humerus, again, a great discussion to bring up with some of your faculty when you're in trauma clinic and you just saw proximal humerus, and you know, Augie's a big nailer, I know, and like, was he nailing proximal humerus? I really wanted to delve into that, but that can be a treatment option too for some of these cases, depending on surgeon preference, fracture type, patient factors, in addition to hemiarthroplasty shown here in the middle. But any questions, Taylor, that we need to address before moving on?
No, I'm bored.
Let's do it. So here's anterior versus posterior, just two different CT cuts, again, showing our first case on the left, a posterior fracture dislocation. On the right side, an anterior fracture dislocation. And you can use the coracoid as a landmark to guide you there. So here we go, clavicle. We're going to hit clavicle, and go ahead, Tim.
If I could just clarify for the students, just to be crystal clear, that last case, the 72-year-old guy, he had a seizure and he had an anterior fracture dislocation. But I think I may have read in one of those little fracture books that when I hear seizure or electrocution, do I think posterior? Is that what or I just want to clarify for them.
That's great, and great point. And I'd say it's probably most common for sure. And I think that's Taylor's case highlights that example where if you have a patient with a seizure with shoulder pain and they show that film, if they show a film and I'm taking my step 1 boards and that's the clinical history, it's a posterior dislocation until proven otherwise. I need to see the axillary. I need to see some sort of cross-sectional imaging to see that that shoulder is not posteriorly dislocated. So most commonly it is posterior. Maybe his subscap was stronger. I don't know. I'm not sure what
Okay.
anterior, but you are correct. All right, Jerry, bring
Okay,
it
let's go
home.
snowboarding.
Let's go. Here we go. Some New Hampshire trauma. Here we go. You got a little snowboarding, little 22-year-old. What's the discussion with this patient? Walks into clinic. What are you assessing? What are you talking about with this patient?
Yeah, so first off, I think mid-shaft clavicle fractures is a great topic for medical students. It's something that we see very often, and something that I think students can get their heads wrapped around and sort of try and understand a little bit more of the nuances. And I think that would really sort of impress your mentors, because we do have a lot of data to sort of guide these discussions. And also, you're oftentimes the first person to evaluate and talk to the patient. So also understanding this can be sort of helpful in terms of guiding patients and comforting patients right at their first meeting. So things that I would want to know is, again, upper extremity, like we talked about before, hand dominance, functional status, those kinds of things that we already touched on with the proximal humerus. Here, because this is a more of a subcutaneous bone, also, exam in terms of neurovascular status, but also, is it open? Is the skin threatened? Is it tented? Is it about to be open? I think the exam also about the appearance is also really important.
Yeah, there's great literature for clavicle. It's a common injury, and so that has lent itself to some great series of operative versus non-operative, and you can really have a great discussion with a patient who can interpret and use those statistics to help guide through the treatment course. So here are a few of those studies. You've summarized it nicely on this slide, just that I think you can confidently tell a patient that 80 to 85% of the time without surgery, you will heal this fracture. And if you, with surgery, that jumps up to about 95 to 99% with the associated risks of surgery. And so operative early function, you get some improved alignment, if it's done early, the surgery is a little bit easier, but for all patients, that I'll just tell them you get one of two things, a bump or a scar. It's just, you can choose, you can have a discussion, but if you have a clavicle fracture, that's often you're going to end up with one of those two things. So here's this patient. I guess he chose the bump, but has this healed clavicle fracture. And in terms of function, I think it comes up commonly, Augie, like at a year, like is my shoulder, if I don't do surgery, am I going to have the same, like is my shoulder still going to work like the same? So what are you telling folks long-term, operative versus non-operative, like for this?
I mean, we have not great long-term data, but I do think at a year and whatnot, the data will show that your shoulder is functional. You're getting back to activity, no matter what that is. Is there like there's always this theoretical rest of the shortening and the strut being a little bit shorter excursion, but it's hard to pick that kind of stuff up. So I'm telling people if it's healed, they're back.
Yeah. I think function's normal. The cosmesis, that has come up. I don't know, Dr. Aker, if you have thoughts on that, if you've ever had a patient come back and been like, boy, I'm 6 months out, but it's drooping so much. That's one, I don't know if I've solved that clinically, who's going to find that important enough for me to actually bring up operative and not just like, here's what your shoulder function is going to be, but any thoughts on that?
No, I mean, I I will have long discussions. Usually we send these patients out of the ER, let them cool off for a week, and usually by the time they come back 1 to 2 weeks later, they are either starting to feel better and already moving their shoulder pretty good, ready to get into therapy, asking to go back to work, or they're the opposite. They're the disheveled, unshowered, miserable, asking for more pain meds. Is there a surgery for this? But in both groups, I do have that conversation about the ptosis or the shoulder droop. I mean, if you stand in front of the mirror with your shirt off, a fractured clavicle, short term, long term, will always droop a little bit compared to the contralateral side. It will never be perfectly symmetric. And if you tell people that, that really does bother some folks, just the way they will look. So while it's not a primary indication, I do think it needs to be discussed with patients so that they're not surprised 3 to 6 months later. Hey, is my shoulder ever going to come up? Just need to have that.
Yeah, agreed. All right, next case here, a little bit more New Hampshire trauma, not snowboarding, but getting on the skis here, and we've got a clavicle fracture. Jerry, is this one different from the radiograph that would drive a different decision-making process? Was this a discussion with a patient that drive a different decision on this case?
Not a different circumstance. This was not threatened or open. Same conversation, just this patient sort of prioritized that they liked the higher chance of union. They liked the fact that the sort of some of the cosmesis, I think this was a female, so some of the other cosmesis factors, and so they chose surgery.
Yeah, I think in general, this is not a bone that's going to realign. Like it's things aren't going to get better. It may get a little bit worse. So if there's a bump and it's an issue, I think to Dr. Aker's point, the exam's critical. If they come in at 3 weeks, and they're kind of, trying to throw their arm up and can't abduct. That probably reflects a lot of soft tissue injury, and that those patients, I will recommend, I'll drive the discussion towards surgery to say, I think you're going to be better with an operation. So we've got
One other,
options. Go
one
ahead.
other, sorry, one other factor to highlight is, function at a year may be similar, but early on function for people who have it fixed, they can, their level, their comfort and their ability to range their shoulder is dramatically improved, I think, from, especially if they start at a point where they're coming in, like Dr. Akers said, they're disheveled, it hurts a lot, they're not able to do anything. Once you fix those people, they do feel a lot better. And if they do light desk duty, it's the difference between getting back to work and being able to do that versus not.
I mean, I would have mine fixed for sure and be operating the next day.
Right. Exactly.
Left non-op, right operative for me personally. Very sided, but sometimes you'll have interesting clinical scenarios, young athletes who fracture their clavicle to where return to play may come in. So these are all really important points as you're deciding what to do. So different ways to fix a clavicle: superior plating, anterior plating, dual mini fragment. This is a really great article, a clinical and a biomechanical study looking at dual plating. That is a great technique that I think a lot of us are using. So you chose dual plating. Dr. Akers shown this has got a pretty low implant removal rate. I've removed one set of plates. I don't know, Tim, have you had to remove any of your dual plates?
I took one out, but that was more of a medical legal. She was like, yeah, my lawyer said I should probably have it taken out. I don't know that she was that symptomatic. I acquiesced and took out the hardware, but in general, no. I think we found only about 3% needed hardware removal compared to the historical norms from anywhere from 10 to 30%. So the mini fragment plates are tiny and flimsy, but with two of them shown to be just as strong or stronger than a single small fragment plate. So tried and true.
Yeah, more literature showing immediate weight bearing may be safe. Certainly, you can do early range of motion on these, so a great technique. And follow-up radiographs here. A picture of an alternative treatment, just a standard superior plating with some lag screws as another option. We're going to finish with a personal favorite of mine, patient, 23-year-old male. His initial shoulder x-ray shown on the left side. He has a displaced clavicle fracture, doesn't look too bad. He gets his dedicated clavicle films. We see a little bit of distraction, maybe a centimeter or so. My antennae are peaked, but then I look at the scout CT of his neck, and he's got the neck to head ratio that's positive. The neck is wider than the head. And you look at the shoulder and the soft tissue envelope, so significant that we kind of just say, you know what, trial of non-operative follow-up 2 to 3 weeks. A week later, he's still hurting his shoulder. He now has like two shoulders from the additional hematoma and the swelling over the shoulder. And we measure, and we've got about 8 centimeters of soft tissue over his clavicle. There's really nothing to discuss here. It's just really me rehashing a really traumatic clavicle fracture with very deep retractors as we use dual plating to fix him. Immediate weight bearing and onto union. Immediate improvement. Couldn't raise the arm. Wakes up in PACU. Thanks, doc. This is so much better. So going back to the discussion with the patient, a high energy, a displaced fracture, failed non-operative, a great indication for fixation. And I don't think I'll have to remove these plates. So that's really wonderful. So thank you, Dr. Aker, for writing that up. So as a recap, we've talked shoulder dislocations, fracture dislocations, anterior versus posterior, clavicle, operative versus non-operative, and plating surfaces. Anything, Taylor, to cover before we call it a night?
Yeah, I think one interesting question about what did you do with that guy who had the seizure relative to his surgery? And what do you do when the head is dislocated? If they're neuro intact, you just leave them and then allow the arthroplasty to occur thereafter. Are you doing some provisional reduction and stabilization? I think certainly if you have a neurovascular compromise in any way, you're going to do some sort of provisional reduction and possibly fixation, even if you think it's likely to fail. But in those arthroplasty settings, did you leave that one and then wait for arthroplasty thereafter?
Yeah, great question. And because they're going to go on to get a shoulder replacement, the head's going to go. So that was left as long as they're neurovascularly intact. I've had one. It's been a few years, but he had an anterior proximal fracture dislocation that was dislocated for like 4 to 5 days because of being an extremis in the ICU. Had a pretty good sized head, and we fixed him, and he did not go on to AVN. So yes, I want to reduce the head whenever it is medically appropriate. In general, those are cases that you can't really do percutaneously. You can't like put a pin in the head and then pull it out. I've been involved in a case where we delivered the head and a rush of blood came from, the deep recesses of the shoulder in front of the subscap. So in those, you want to do open, controlled reduction of the humeral head. And so I'm going to do that in whatever setting. If that means waiting a couple of days because the patient's not well enough to undergo the operation, I will. I think one of the challenges, clinical conundrums that I find residents are into is the dislocated shoulder with a non-displaced proximal humerus fracture, and how exactly to manage that, where you can see on the CT scan that there's a neck and the shoulder's out the front or the back. And so I think it's always good to load the boat on those. And you may have some faculty say, give it a try, gentle pull in the ER, or take it to the OR with good relaxation, gentle attempt, or pin it and then reduce it. So I don't know, Dr. Aker, you've got a ton of experience on those. Any cases or pearls, kind of thoughts that come to mind with those types of cases?
No, I think that a gentle reduction maneuver is almost always warranted, excepting that you've got a good neurovascular exam and things are normal. I would always, if you're ever in doubt, just always bump it up. If there's a question, if the exam is cloudy, if the pulses are thready, anything unusual, just bump it up. No med student or intern has to make complex decisions about injuries around the shoulder, such as those.
Yeah, we've had a case with a vascular injury, proximal fracture dislocation, thready pulse. They get a CTA. There's a vascular injury. That really will change the treatment. And as the resident, you may be the person to pick that up, because the trauma team may not know that the anatomy in that location, and this they actually get further evaluation. We do the ABIs for the distal femur fracture. I don't know, for some of these proximal humerus, you may want to check the blood pressure on both arms, check the pulses on both wrists to assess if they're equivalent, because I have seen that before. So
Yeah, but similar, Phil, just to piggyback off that, I know we're out of time, but for the 80 participants that are still logged in, I think a word that is worth remembering and reading about: scapulothoracic dissociation. I thought maybe that's where your last case, the guy with the big neck, I thought maybe that's where you were going with that, but that is the term scapulothoracic dissociation. Devastating injury that sometimes it's surprising who in the chain of command picks up those injuries and is able to really save an arm and potentially save a life. So I would encourage you to go home and read about it. We're out of time tonight, but you could really be a superstar if you are aware of that diagnosis and can describe it.
yeah, great way to finish, Dr. Aker. And we thank you all for tuning in for our shoulder girdle discussion. And we are on to infections next month. You get to hear about one of Dr. Young's cases here. Things look
Not
so
my
good.
infection.
It wasn't yours. Sorry. Referral to clinic
come
with
on.
this wound. Exactly.
Oh, Taylor, Taylor,
Manage
come
others
on, man.
So
I have plenty. I'll own the ones that I ate, but I'm not taking credit for other people's.
So we look forward to seeing y'all next month. Really appreciate Augie and Jerry being on tonight, and all that the cases, excellent x-rays, and then excellent teaching points to give to our students. So thank y'all. Check your email for your Credly badge. Get that on that application next year, and then check YouTube. for this episode and then other ones that we've done in the past. We thank everybody, and thank you, Dr. Aker and Dr. Young as well.